I'm Dr. Sam Mann, and this is Beyond Conventional Medical Thinking. And I have an interesting topic today. Are you drinking too much water? A lot of patients and physicians are often concerned, are you taking in enough fluid? Are you drinking enough water and other fluids? There's also another concern, though. Are you taking in too much fluid, and can that be harmful? And that's what we're going to talk about. In this podcast, I'll be discussing how much fluid a day should we take in. The automatic answer that we all hear all the time is 8 glasses a day, but let's be more specific about that. And what do the guidelines tell us? Are the guidelines right? And what is best for us? So the American guidelines, National Academy of Medicine, they recommend a total fluid intake of 3.7 liters a day. Liter is pretty much the same as a quart, slightly different. For men, and for women, 2.7 liters a day. Interestingly, the European guidelines for men versus the 3.7, for men, it's 2.5. And for women, it's not 2.7, it's 2.0. So their recommendations are a lot lower. I mean, maybe European people are smaller people, but I doubt that. So then the question is, who's right and who's wrong here? Um, Another important point is that we have to keep in mind food also contains water in it, and about 20% of our fluid intake comes from food. So when we think then of the fluids that we need to take in, we have to subtract that 20% that comes in the food. And that means that instead of 3.7 liters a day or quarts a day, it's really 3 liters a day. And that 3 liters is the equivalent of about 12 to 13 glasses of water a day. Now, that's almost 3 glasses of fluid every 4 hours, every 4 waking hours. We don't drink in the middle of the night. That's almost 3 glasses every 4 hours. So for women, instead of 2.7 liters, it's 2.2, and that's the equivalent of 9 glasses. And of course, there are many factors. We differ in size, we differ in physical activity, but should we be drinking this much fluid? Is there an alternative to the guidelines? The one logical alternative is that old thirst mechanism. Evolution gave us the thirst mechanism. When we need fluid, we feel thirsty. When we feel we have enough water, we don't feel thirsty, and it works. One possible exception in the older population, the thirst mechanism is less active, and therefore they might not drink enough fluid. And sometimes it's recommended by guidelines actually to have a planned fluid intake to make sure an older person gets enough fluid rather than rely solely on the thirst mechanism. Another important question is how much fluid do we lose in sweat? And on average, about half a quart, half a liter, uh, which is minor compared to all this fluid we'd be taking in. Obviously, if we're in very hot weather or intense physical activity, we sweat more. And on those days, we do need the increased intake, and our thirst mechanism usually tells us that. Now, the other important question is, okay, so we drink in this extra fluid. Can this extra fluid be harmful to us? If it's not harmful, it's not such a big deal. Can it be harmful to us? Certainly, there are people who need to have the adequate or extra fluid intake because of medical conditions. They absolutely need to be compulsive about fluid intake. These include people who have recurrent urinary infections, and the recurrence is helped by the urine flow rather than stagnant urine sitting there. Best to have an increased urine output to help prevent recurrent infections. And the other key question, indication for making sure we have plenty of fluid, is in people who have kidney stones. And there also, we want a more dilute urine to prevent recurrent stones, and increased fluid intake helps do this. So, in patients with recurrent urinary infections or with a history of stones, absolutely the amount in the guidelines should be followed. Now, are there any negative effects in the rest of us um, that we should be concerned? Maybe we shouldn't have this extra fluid. Can it do harm to us? And the answer is yes, and I'm going to focus on two adverse effects. One common yet overlooked, largely overlooked adverse effect that I see in many patients when I take a medical history and I ask a patient if he or she gets up much at night to urinate, to pass urine. And some people will tell me yes, two, three, or more times a night. Getting up three times a night to pee is a nuisance. Not only is it a nuisance, it interferes with getting a good night's sleep, and that can't be healthy. Um, it's a real problem, yet it gets little attention. And some people who get up so frequently have a bladder issue, but usually in those patients, if I ask them, do they drink a lot of water? Almost all of them give me the same three-word answer. They say, I try to. They try to take in a lot of fluid because that's what the recommendations are, the guidelines. And the fact that they're taking in so much more fluid than they need, that's why they're getting up two, three times a night. And that is so simple to correct. And that affects millions of people and who don't get much benefit from all that fluid they're taking in. And they have trouble uh, with interference in their sleep. I advise them, when you're thirsty, drink what you want. Skip the glasses of water that you do because you think you need it. And when they do that, they get up less to urinate and they feel much better because of that. So, other than people who have kidney stones or recurrent urinary infections, maybe it's best that we don't drink all that extra fluid. Now, what is the other adverse effect of consuming a lot of fluid? Something called hyponatremia, a low blood sodium level. The more fluid you take in, the greater the chance that your blood sodium level will be low-ish. And if it's low, and the normal sodium level, blood sodium level is between 135 and 145. If it gets down below 135, and particularly below 130, it can cause problems. It can cause fatigue, nausea, confusion. If it's really low, even seizures. And the problem is also that we can develop a low blood sodium from excessive fluid intake. We also can get a low blood sodium level from the most popularly prescribed diuretic, the thiazide diuretics, such as hydrochlorothiazide. And about 10% of people who take hydrochlorothiazide can develop a low blood sodium level. And if they drink a lot of water, it's much more likely, but nobody talks about that. So, are there any tests that can serve to tell us if our fluid intake is too much? Not really discussed in the literature, but there are two logical clues. One, which we just mentioned, is the blood sodium level. And if I have a patient whose blood sodium level is 133, I will automatically ask that patient how much fluid they take in. And 9 times out of 10, they drink a lot of fluid. And they're at risk for the sodium level dropping either further and becoming more symptomatic. So if you're about to start taking a thiazide diuretic, be careful about all that extra water that you take in, because between the water and the diuretic excreting sodium, you're at a big risk of hyponatremia, low blood sodium level on a thiazide diuretic. And if you are on one, your doctor should check your blood sodium level. Then there's another clue that your fluid intake is too much, and it doesn't exist in the literature, but something I've been looking at for years, clinical experience looking at patients and charts, is the blood uric acid level. And we check a uric acid level. Usually, we're concerned about it being too high because a high uric acid level can lead to gout. And diuretics, and particularly thiazide diuretics, do increase the uric acid level because when they excrete sodium in the distal part of the kidney, um, it holds on to fluid sodium. It reabsorbs sodium and uric acid. So thiazide diuretics typically cause an increased reabsorption of uric acid, and it raises the uric acid level. And every doctor knows that. And if the uric acid level is high or there is gout, we know what to look for. On the other hand, very few people talk about the opposite end, which is if the uric acid is low-ish. Now, the normal range is between 4 and 8.5 in men. And if I see a patient whose uric acid level is below 5, and particularly if it's below 4, again, my first question is, do you drink a lot of water? And I get that 3-word answer, I try to. If the uric acid is below 4 and you give that patient a thiazide diuretic, the chances that they will develop hyponatremia, the low sodium level, is much more likely. And in fact, if a patient has a low uric acid, I'm afraid to prescribe a thiazide diuretic. Although, unfortunately, fewer and fewer doctors are monitoring or checking the uric acid level unless they're concerned about a high level or gout. But it's a useful clue and a warning sign. A low uric acid level in the blood, start them on a thiazide diuretic, you have an increased risk of hyponatremia, low blood sodium. So, what can we do about it? Well, number one is to advise to hold off on the extra fluid. Um, and in particular, if somebody has a high fluid intake and a very low sodium intake, and you give them a thiazide diuretic, they're even at higher risk of developing hyponatremia. So it's very important, and your doctor's not going to ask you if you drink a lot of water. Keep it in mind. So, what can we do about it? If you need a diuretic, you need to excrete salt to lower your blood pressure, or for heart failure, or for kidney disease. There is an alternative, and that's called a loop diuretic, and there are a few on the market. The loop diuretics work in a different side of the kidney, and they differ from the thiazide in that the loop diuretic does all its action within a few hours. After that, the effect wears off till you take the dose the next day, whereas the thiazide is operative most of the day in most people. And so the loop diuretic gives you time, gives your body time, your kidneys time to hold on to sodium and to recuperate from the effect of the diuretic. So it's safer. Which diuretic would be best? Which of the loop diuretics would be best? Most physicians prescribe the loop diuretic that everybody's familiar with, which is Lasix, furosemide. It's by far the most famous. I don't, for a few reasons. Um, One, and I prefer torsemide for 2 reasons. One, the Lasix, the furosemide, its effect is a little briefer than that of torsemide. And if you look in the guidelines, it says that for hypertension, the Lasix is effective if you take it twice a day. Now, I wouldn't prescribe Lasix twice a day to my worst enemy unless they really needed it for resistant heart failure or something. I would never prescribe a loop diuretic twice a day. It's cruel. The torsemide, its effect is a little bit longer, maybe 4 hours. It's actually recommended once a day for hypertension. So it's a better fit. Now, the other problem with Lasix, furosemide, is that what percentage is absorbed when you take a pill? Anywhere from 10 to 90%. Its absorption varies tremendously from one person to another, so that the blood level you get of the drug varies hugely from one person to another. The torsemide is very well absorbed, very predictably absorbed, so you don't have that variability of blood level. And I'll give you one other tip. When I want to know, is the dose of the loop diuretic enough to do the job? There's a simple question I can ask the patient to find out. Doesn't even need a blood test, although we get blood tests routinely to check the blood in patients who are taking a diuretic to make sure there's no adverse effect. But the question I ask, is the dose enough? The question is very simple. When you take the Lasix or torsemide, does it make you pee extra? And if it takes the patient more than 2 seconds to answer, then the dose is not enough, because the usual answer is, oh, yeah, because you feel it. You pee a lot with it, but again, only for a few hours. And the important thing is with a loop diuretic is you don't have to take it in the morning and not at night. You could take it whatever time of day is convenient for you to have that extra urination. If necessary, on a given day, let's say you take it in the morning, and you have stuff that you don't want to take it that morning, you can take it in the afternoon. You don't have to take it the exact same time every day. I'll give you an example. A patient of mine was late for an appointment, and he explained why. He said he took his loop diuretic in the morning, and then he got in his car to drive to my office, and by the time he got to the RFK bridge, he had to pee. He had to stop his car in the middle of the bridge, get out, pee over the side of the bridge. You could call that a diuretic-induced traffic jam. But I said to him, hey, don't take it before you're going to go on a car trip, and you can vary the time to suit your convenience. And one other useful trick with the loop diuretics is also something that you won't find in the books, but it makes perfect sense. If I have a patient who needs a diuretic and they have a history of getting up 2, 3 times a night, obviously I'll check about how much fluid they take in, but also um, if I give them a thiazide diuretic, it may actually worsen the getting up at night to pee. In that case, I use a loop diuretic, and a loop diuretic lowers blood pressure as much as a thiazide diuretic. And the nice thing is, when should you take that loop diuretic? And in those patients, I recommend, why don't you take it late in the afternoon? And it'll make you pee more in the late afternoon and evening, so that by the time you go to bed, you'll need to get up less in the middle of the night to pee because you've already peed a load of urine while you were awake. And I've used this strategy for patients who need a diuretic and get up at night 2, 3, 4 times. And it almost always reduces the frequency of urinating at night. So keep that in mind. And also switching from a thiazide, which works over most of the day, to a loop, and by the time you go to bed, its effect is over. So it's, I think, very valuable, very practical advice. So we come back to the question, do we really need these guidelines about fluid intake? Are too many people drinking too much fluid? And I think the answer is yes. Again, if they don't have the indications of the kidney stone or recurrent urinary infections, yes, it helps prevent dehydration, but our thirst mechanism, except arguably in older patients who need to be more conscious about taking in fluid, our thirst mechanism usually works. So it's very few people that drinking all this extra fluid is helping. And again, the harm of the risk of a low blood sodium level and the getting up at night to urinate because of so much fluid intake. So I think that it is not right that guidelines should be followed by everybody to have all that fluid intake. And again, if the guidelines are telling you 3 glasses of fluid every 4 waking hours, Nobody's going to do that. Let's be realistic here. If it's very hot weather and we're sweating a lot, or if we're going to exercise fiercely, absolutely take in the extra fluid, whether you do it ahead of the exercise or partially ahead and after. And it's interesting. There was a study once done of New York marathon runners, and they measured various things before they ran it and then after they finished it. And one interesting finding is there were a significant number of marathon runners whose weight was higher after they ran the marathon because they were drinking fluid more than they needed. So that's an aside, but it's interesting. But the 3 liters that the guidelines are recommending, I don't think they help most people, and they can have the side effects. And again, evolution gave us a great thirst mechanism that works very well in most people. One warning, if you have a very low sodium diet and drink a lot of fluid, you're more at risk for that hyponatremia, the low blood sodium. So what's our take-home message? Take-home message is the guidelines tell us 13 glasses of water for men, 9 for women, but they should not be blindly applied to everybody. There is a downside to excessive water intake. Again, the risk of the low blood sodium, and particularly in people who have a low salt intake or people who are taking a thiazide diuretic or some other medications, antidepressants, particularly a select SSRI, can be associated with a low blood sodium. It increases the risk. And NSAIDs, the anti-inflammatory drugs, also with a lot of fluid intake can give you a low blood sodium. So if you're taking a thiazide diuretic and you're a big water drinker, make sure that they check your blood sodium level. The uric acid level is also a clue. Consider switching to a loop diuretic, which lowers pressure just as much and has less risk for the blood sodium drop, and also less problem with frequent urination at night. And finally, 2 logical strategies relevant to prescribing a diuretic that most doctors don't consider, but I think your doctor should consider, and you can bring this up to him. One is the idea of we take a dose of a diuretic every day. Is it logical to vary that dose sometime? So if you're eating night after night in a restaurant, maybe take a dose and a half of the diuretic some of those days. Or if you're eating very little, maybe take a reduced dose. Or if you're sick and not eating anything, skip the diuretic that day. I think there's less of a chance of getting into diuretic-induced trouble if you have a little bit of flexibility in how you take it, and you can discuss this with your doctor. And as I said, the other thing is if you need a diuretic and you're getting up multiple times a night to urinate, consider a loop diuretic taken in the late afternoon. It almost always reduces the getting up at night to urinate, and what a blessing that is. So I hope these pointers will be helpful to many of you who are listening to this podcast. Again, I don't think rigid adherence to the guidelines in terms of fluid intake is the best advice for everybody, and it might be more harmful to more people than it is helpful, given that we already have a very effective thirst mechanism. And again, we need to individualize. There's no one rule that should be applied to everybody. And please bring attention to this podcast contents to your friends and relatives. And if you have any questions or comments, you can reach me through my website, Dr. Samuel Mann, MD. And thank you for your attention.